Good morning, everyone, and thank you for joining us with the EDC Coffee Chat, Coffee with Colleen. We are honored to have our EDC Chair, Jennifer Burkhardt, on with us today. She is also the Chief Human Resource Officer and OMC's General Counsel. So just a few housekeeping items. If you put yourself on mute, please, so that we can ensure that we don't pick up any inadvertent backup noises. And if you have any questions, go ahead and raise your hand or put your question in the chat and we'll call on you. So with that, Jennifer is all set and ready to present this morning on the two big topics, I think, the changeover at the emergency department, and then also the changes with CMS, which are a big thing to celebrate. And we're just really very appreciative of Jennifer and all she does, not just for OMC in her full-time capacity, but also certainly with the EDC. She is instrumental and helps not just our community and our EDC, but she does support presentations in her wearing her legal hat, explaining to all sorts of nonprofits across our county, but then she's also offered presentations and explained how to update bylaws to EDCs across the state. So with that, thank you very much, Jennifer, for joining us again today and sharing with everyone the update at our largest employer, OMC. Thanks, take it away.
Thank you, Colleen. That's such a nice introduction. Good morning, everyone. For those of you I haven't met, I'm Jennifer Burkhardt and a big supporter of the EDC, and so really thrilled to be able to share some updates about Olympic Medical Center with such a great audience. I do encourage questions, and there may be some controversial questions. There may be some that I'm unable to answer on the spot, but I'll always take them back and try to obtain answers. And I prepared remarks, but nevertheless, please interrupt with any questions because I would rather focus on anything of interest to you and our economic development in the county and our EDC. So with that, I will start with some good news, and that is the site neutral development that we have recently had with CMS, as Colleen mentioned. And some of you are very, very familiar with this story. Others might be relatively new to it. So just to set the framework so that we can really all share in the success of this together, I will start 4 long years ago just to build the history so that we're able to really focus on how Clallam County is benefiting from a seemingly far away decision in Washington, D.C. to reverse a rule that was very negative for us. So this was 4 long years ago, and when I look back, it's hard to believe that it was actually in a time long before we had heard of COVID. We were focused on other threats and other concerns, but our beautiful and rural Clallam County, our picture-perfect North Olympic Peninsula, faced a threat not of COVID. We hadn't even really heard that that was on the horizon yet, but we faced healthcare reimbursement being cut, particularly in rural counties. So at that point in time, we had heard that there was rumbling in Washington, D.C., and in politics that rural healthcare was going to be threatened. CMS had actually formed, and to this day has a focus on rural healthcare. They have a subcommittee that is charged with looking at the effects on rural healthcare of reimbursement measures. But even though that was part of the analysis even 4 years ago or so, there was a decision that was made based on a MedPAC recommendation, which is a third-party organization that looked at the way reimbursement was occurring for hospitals and physician groups across the U.S. And MedPAC proposed to CMS that it might be able to save money, which of course was highly attractive to CMS in terms of trying to administer Medicare and Medicaid services. And to back up one step, CMS, the Centers for Medicare and Medicaid Services, is the government agency. It operates under the executive branch, under the President of the U.S., and it's the organization that is charged with oversight of Medicare and Medicaid across the U.S. So that is reimbursement for healthcare services for any program that is government-based and falls under the Medicare umbrella, which is quite a few. So in July of 2018, we received the very devastating news that a proposed rule out of CMS had slashed reimbursement for rural provider clinics. At that point in time, Clallam County came together, and this is actually a picture of Eric Lewis, who was our CEO at the time. And Eric and others, including myself and many of you on this call, participated in efforts to ask others in our county to submit letters to CMS, because one of the ways that you can affect change with an executive branch decision, such as a proposed rule, is to submit in a 60-day window before the rule becomes final, comment letters. So at that point in time, we asked the community to come together and to share concerns about rural healthcare being threatened in this way. And Clallam County, to its vast credit, submitted 1,800 comment letters to CMS, which was more than any other region in the country. And CMS learned where Sequim and Port Angeles were located and why site neutral mattered to us at the time. We participated in phone calls with the CMS executive agency heads. We participated with our regional executives on CMS, and we really talked to them about the issues. And we explained to them that this is a negative impact for a rural healthcare community if you slash the reimbursement in this way. So despite our best efforts, the final rule was implemented, and it went into effect, significantly cutting the Medicare reimbursement rates for hospitals such as OMC. And what it did was reduce the percentage of reimbursement for off-campus, that is not located on hospital property, clinics by 60%. And what this meant for us is that rural areas like Sequim in particular, and also parts of Port Angeles and other parts of Clallam County, were especially hard hit. And that's because the effect of the rule was to say that because the reimbursement would only be whole on the hospital campus, we would have to consolidate services to our hospital campus, which is located, of course, in Port Angeles, and it's one location, one facility. So that had the very detrimental effect of causing us to consolidate and also to reconsider being able to provide services across Clallam County. And one of the things that we had pointed out to CMS in our letters was that Clallam County is actually as big as a small state such as Rhode Island. So Clallam County, despite having fewer individuals, because we are a rural setting, is a fairly large geographic region. So to serve our residents of Clallam County, it's really needed to have clinics and other resources across the county. So as I mentioned, this rule was really devastating. The impact was a cut of 60% for any clinic that's located more than 250 yards from the hospital. So Sequim, of course, was deeply affected, and we had plans for services that were affected and put on hold at the time. And Port Angeles, where we had clinics on Vine Street and Cherry Street and elsewhere, was affected as well because those clinics would face the same kind of reimbursement cuts. So all of the growth that we had planned for these various areas was put on pause. For example, in Sequim, we had a $5 million primary care expansion that we knew was necessary. And although our partners in the community have really stepped up, and I think we've all worked together to bring more primary care to Clallam County, we still see in recent surveys that approximately 8,000 residents of Clallam County are without a primary care provider. And so we know that that's a need, and we need to continue offering more primary care because that's also the way to slow the services that might be required in the emergency room or other acute care settings if we can really treat our residents at the primary care level. So that was a big and devastating cause or result of the cuts at that point in time to halt the primary care expansion, at least for a while. We also had at that moment in time a $10 million ambulatory surgery center renovation for same-day surgery planned in Sequim. We had purchased the same-day surgery clinic, and although it needed quite a bit of updating to the tune of at least about $10 million, we were poised to do that, along with other service lines where we had been hearing from Sequim residents and others throughout the county what might be needed. So all of that was put on hold because with a 60% cut, it became really not very feasible. And I should mention that the 60% cut to Medicare is a cut to a reimbursement rate that is not 100% to begin with. It's actually about 70% of cost. So if you slash that by 60%, you can see that the economics begin to become impossible. So what did we do at that point in time? Well, it's America, so OMC sued. We were actually invited to participate in litigation that was filed by the American Hospital Association. And one of the reasons that we were invited to participate is because we were really a case in point for how bad this policy was. And the AHA recognized through the efforts of Eric Lewis and leaders on our board. I see John Nutter here, who was one that spoke up, and also our community partners, who many of the leaders that are on this call, who spoke up and talked about how devastating this was to a rural community. It might work in an urban setting where you would have more consolidation already, but this was going to be very difficult. So along with 4 other hospitals, we were invited to join this litigation that was filed in December of 2018. And initially, we had a very positive result, and we won at the district court level. This was filed in the District Court of Columbia in Washington, D.C., because it is a federal issue and it's against an executive branch agency. We had a great victory at the trial court level, and the district court ruled in our favor, and we won. And the decision was that the agency had overstepped its authority in ruling in this way, and that the effect was too detrimental on rural communities as a result. Unfortunately, that was appealed by CMS, and at the 10th Circuit Court of Appeals, we lost on appeal. So at that point, we tried to take it to the Supreme Court, and this case would go all the way to the petition for certiorari at the Supreme Court level, but the Supreme Court declined to hear the case, and cert was denied. So at that point, the case was over, litigation was a dead end. So the next way that we attempted to affect change was through an effort that Congressman Derek Kilmer, who had been a great ally throughout all of this, shored us up by doing. And Representative Kilmer actually introduced legislation, the PLACE Act, which stood for Protecting Local Access to Care for Everyone. And he was introducing this legislation in order to legislatively overrule the CMS rule that was now in place that cut the reimbursement by 60%. So the law would then say at the federal level that reimbursement for certain categories of hospitals, such as OMC and other Soul Community hospitals, would stay intact, what it was before, the 70% level. That bill was able to pass in the House of Representatives, but it eventually stalled in the Senate. And at that point in time, despite Representative Kilmer's great efforts to move this forward and his discussions with many community members, and as you can see from this newspaper article pulled from the archives, he visited Sequim and talked with Sequim patients and residents. Nevertheless, the bill stalled in the Senate, and at that point, a legislative remedy seemed to be dead as well. So fast forward 3 years. And by fast forward, I don't mean that any of our local community leaders, those on the call, our politicians, our allies, were sitting still and doing nothing. There were actually many, many efforts underway during the last 3 years. They didn't all make newspaper headlines, but there were a number of efforts such as trips to Washington, D.C. Again, many that are on the call, including Commissioner Nutter, participated in meetings with Congressman Kilmer, with Senator Cantwell, with Senator Murray, both on the Hill and in district, We made ourselves, I wouldn't say pests exactly, but we kept in very close contact with the legislative aides for those legislators, and we made numerous visits and calls to them. We also kept in contact with CMS. The Deputy Administrator, Dr. Meena Seshamani, was interested once the administration had changed in learning more about OMC, and Congressman Kilmer was instrumental in really getting together with CMS and making the case for us to the point where CMS invited us to participate in a virtual visit where CMS would converse with us and talk with OMC officials about the effect of the rule. We also had regional meetings. One was with John Hammerland, who's the Deputy Director for CMS. And at Congressman Kilmer's urging, we participated in a number of rural listening sessions and remote forums where we were able to make our case to CMS. So with all of that, just a little over a month ago, about 6 weeks or so now, on July 15th, 2022, we received the incredible news, and I will say it was a momentous day at OMC and for Clallam County when we learned that the Centers for Medicare and Medicaid Services was proposing a rule that would reverse site neutrality for rural cell community hospitals. So what we had done is worked with CMS to carve out a category of hospitals that would be exempted from that site neutral rule. And sole community hospitals are those such as OMC, which operate in rural settings and provide services to a wide swath of individuals over a geographic area that is bigger than that in urban settings or smaller states. So we celebrated, we are still celebrating. OMC has gotten this good news. Our community is thrilled and should be thrilled about this. It will be a significant boost in our reimbursement. Now, again, it's back to pre-CMS rule levels, which are, again, only 70% of cost. So it's not a windfall by any means, but it really does help for purposes of our planning and our moving forward, and especially for us being able to serve individuals beyond the four corners of our hospital campus. So what does this mean for SQUIM and really the rest of us as well? Our recent strategic plan had assumed that site neutral would continue, meaning the reimbursement cuts would be in place. We had also undergone just this year a master facility plan and the development of that. And in so doing,
Sorry about that. Let's see. I'm trying to see who's providing background noise. And try again.
all right, are you okay with sound?
Mm-hmm.
Okay.
I believe so.
Thank you so much for fixing that. As mentioned, we had assumed that this bad news would continue in perpetuity, even though all of these efforts had been underway for years. I think all of us considered it to be somewhat miraculous when we did get the news that Congressman Kilmer had done so much work with CMS and that the rule was being reversed. So at this point in time, we're reassessing, of course, the strategic plan and our master facility plan, and trying to relook at some of those plans that had been paused, including primary care, how we can support the community, what service lines might be needed, and whether the ambulatory surgery center is something that we can continue as well. So when the rule is finalized in November, which is really when we'll know for sure, right now we're waiting with bated breath and crossed fingers, at that point we'll have a really concrete opportunity to take a look at those plans and revisit all of those strategies. So next steps. Just as before, when CMS had issued its proposed rule, there's a 60-day window that started July 15th, where CMS accepts comments on the proposed rule. So just as before, we are encouraging our community to speak up. And there may not be 1,800 letters that go in this time, but we're hoping that there will be at least some letters that will go forward thanking CMS for this rule and explaining why healthcare is important in our rural setting. We have provided a template letter, and I emailed that to Lori earlier, and we can certainly redistribute it to those on the phone. The template letter asks for individuals to just share their story about why healthcare is important and why the proposed cuts were detrimental. I will say that although it's a very comprehensive, robust letter, a resident could say something as simple as "thank you for this rule." It will really help our community. And I think from the CMS standpoint, that would be heard and listened to. And so we encourage any sort of letter. It doesn't have to be as complex as the model template, which is provided for folks. It can also just be a simple thank you or a thumbs up in favor of this move. So a big thank you to wrap up this particular topic. Going back 4 years ago, you as our community really mobilized, and we had never seen the type of unprecedented letter writing campaign that was started. The real estate groups chimed in, the business groups chimed in. I know the EDC was instrumental, our Port Angeles Business Association, the SQUIM and Port Angeles Rotaries. There were just so many groups, too many to name, and hundreds of individuals that all mobilized and launched that letter writing campaign, which made a big difference. We also owe a thanks to Representative Derek Kilmer, who didn't give up. He literally is the embodiment of tenacity on this issue, and he never stopped working behind the scenes, which was just amazing and inspirational to all of us. And I have to say, we at OMC are just really impressed and thankful for the amount of time and energy he and so many of our leaders, including a lot of you who are on today, poured into advocating for rural healthcare in Clallam County. So a big thank you, and we hope that as of November, this is finalized, and urge you to send in a note of support.
Thanks, Jennifer. There were some conversations in the chat, and so I know Debbie Fuson had asked a question, and John was explaining it. John, do you want to chime in here a little bit and explain the different categories?
Sure. The question had been posed of, why did this not apply to Port Townsend and to Forks? And that's because they're in a category of what's known as critical access hospitals. And critical access, they can't have more than 25 beds, and basically they get full reimbursement from Medicare and Medicaid. They get 101% of cost. And so this rule didn't apply to them at all. I don't like that rule, that they can spend whatever money they want and they always get 100% reimbursement. Unfortunately, that's not the world we live in. And so we have to live with the fee schedules that Medicare puts out. And Jennifer did an outstanding job explaining this, that, unfortunately, it's not the silver spoon that's going to make us better. We've gone from 45% of cost to 70% of cost. That means we're still losing money on every patient we see, but at least we're going to lose less. And ideally, we'd be able to get reimbursement like Forks and Port Townsend, but that's not likely to happen. So kind of is what it is.
That seems unsustainable to have that level of reimbursement rate. How do you handle that?
It is highly unsustainable. I mean, I can point out examples of, rural Eastern hospitals that are buying $1 million robotic machines for doing surgery. Well, they get reimbursed at 100% of it, so they don't care what they spend. In the labor market, we compete, for nurses, medical assistants, CNAs, doctors. We compete with Forks and Port Townsend. They can pay anything they want and they get reimbursed 100%, whereas we have to live within our revenue stream. So there is no simple answer to that. You just have to make the best decisions you can and move forward. And right now, to be honest, we're losing over $1 million a month from operations. Now, we've had a little bit of COVID money that carried us through part of the year. We get a little bit of tax revenue, but we're not in a sustainable position. And so that's why we go through some pretty challenging strategic planning processes, trying to figure out where do we go into the future. So
wow,
lots more to come.
Well, that's alarming.
Yep.
I saw that Rebecca had a hand up. Rebecca, do you have a question?
Sure. Good morning and congratulations on that. That's such a great thing to have happened. Jennifer, I thought it might be interesting for people to understand, good morning, exactly why CMS originally did this, because it wasn't with bad intentions. I think it just affected us in a different way. but with the competition with doctors in urban areas? I just thought it might be interesting.
Yes, great question, Rebecca, thank you. This rule that was proposed is called site neutral, and you've heard me refer to it as such, kind of for short. And the reason it's termed that is that going all the way back to that third-party think tank that I mentioned, MedPAC, which is a group of highly educated experts in healthcare in the DC area. That group looked at reimbursement across the US and noted that hospitals are typically reimbursed at a higher rate when their services are provided on campus because they're in a hospital setting. So the hospital physician visits and services have one rate of pay, where physician services that are located in independent physician practices are reimbursed at a higher rate of pay, or I'm sorry, a lower rate of pay. So what, as hospitals began to acquire more physician clinics, and part of that is that physician clinics were finding, even though they had a slightly higher rate of pay, they have a lower rate of pay, they were finding that it was very unsustainable to continue their individual physician practices. So they were asking hospitals to join those systems. And then some of the physician practices were being reimbursed at the higher hospital rate. Hopefully that makes sense. So MedPAC looked at this phenomenon that was happening across the US with physician clinics joining hospital systems and now charging a higher rate of pay, again, still a percentage of cost. And they thought that that was an unnecessary expense. And so what should happen is to create this site neutrality so that when you're off campus and not on a hospital facilities campus, you have a neutral method of payment for physician clinics, meaning those that are independently owned as well as those that are owned by hospitals would all have the same lower rate of pay. So the effect of that for us was to say that, for example, the medical services building in SQUIM, which is all hospital-based services because they're part of OMC, those physician visits would now be reimbursed at the lower level as if they were independent. And part of the problem with this in a rural setting is that we really don't have a plethora of independent physician clinics any longer. In the distant past, there were more, but now really the primary care and the physician services are provided by our partners at KNOWN, a federally qualified healthcare clinic, and the Jamestown Tribe through its family healthcare clinic, and then through OMC. And there are only a few scattered independent physician clinics, which means that if you reimburse the OMC providers who are located off campus at this lower rate of pay, it really affects Clallam County because we don't have the backup that perhaps Seattle or King County might have in terms of independent physician practices.
Mm-hmm. So I saw that John Nutter said that Medicare is reimbursed at 70%. What percentage of your patients are Medicare payees? And then also, what about Medicaid? What percentage is that reimbursed at?
So we're a little bit over 80% government payer, which includes Medicare, Medicaid, TRICARE, CHAMPUS, and several others. We're running about 55% Medicare and 10 to 15% Medicaid, which pays even less. And unfortunately, what that does is that we call it cost shifting. That means that the 15% of commercial patients that we have, that's where we have to make all of our margin. And I think that's absolutely wrong, but I don't get to make up the billing rules.
And
yeah,
so,
and I would say, oh, go ahead, Colleen.
If you have your own healthcare coverage, does that just mean my insurance company is paying more, or is that my my premiums or my copay or whatever is higher as well?
Both. Because that means that, the commercial segment of our business, they have to pay, 120% of cost to make up that margin. And unfortunately, over time, that segment of our patient population is getting smaller and smaller. As our population ages, more people are moving to Medicare or to Medicaid. And so our basket of the commercial payers is getting smaller by the day. So fewer people paying the full cost of care, which just leads to challenging economics.
Yeah, absolutely. And do you envision that changing at all in the future?
I think it's going to have to, because we're going to see just an utter implosion of our entire medical system. We are not unique out here. No, we don't have the advantage of some of the urban hospitals that have, you go over to Overlake and in Bellevue, we're at 55% Medicare. They're like at 15% Medicare with a much larger, they have a bunch of Microsoft employees that all have really good medical plans. But rural healthcare is really suffering right now. Washington State Hospital Association has started doing some studies now that, rural healthcare is not in a sustainable position. So fortunately for OMC, we have some really good reserves. We have a really good management team. We have some strategies, and we're not going to be the canary in the coal mine. We are far better off position than a lot of other rural facilities. So once some of those disasters start happening around us, I think that's going to help.
Great. Ray Triath had a question. Ray?
Yeah, I was wondering if, first of all, congratulations to everybody who was involved in getting this passed. Does any of this go into effect retroactively by any chance, or is that hoping for too much?
No, not retroactive at all.
Thanks.
Yeah, good question. Unfortunately, no. When CMS was taking back money from us, that went retro, but not the other way. So we're disappointed with that. The delta that you mentioned, Colleen, I was just going to comment that 70% of cost, it really is a big lift for us, and we've been trying to continue our advocating for that reason also, because if we advocate with our representatives in DC as well as our local representatives, then we can ask for sole community hospital add-ons. We can ask for increased assistance with what are called 340B drug pricing efforts. There are some things that can be done to help make up that delta, but it's a big lift. So that's why we continue to work on those enhanced payment models and trying to create the government payer system that's robust enough to not rely on the private insurance sector as much, because that's not a sustainable model either.
Are there some service categories that have a much lower reimbursement rate than others?
Yes, in general, Medicaid reimburses much lower, as John had said. And so, for example, in pediatrics, we serve approximately 5,000 pediatric patients in Clallam County, and the vast majority of those in our system are Medicaid supported. And that's not an area that is reimbursed well, but it's obviously an area of need and one that we wouldn't reduce services. And similarly, we look across at all of the service lines on a pretty continuous basis, as John was mentioning in our strategic planning, trying to ensure that we're losing the least amount of money while fulfilling the most needs for our rural community. And it's a tenuous balance. And again, we share that burden with our community partners who've really stepped up, and we're grateful that we have a collaborative kind of setting with our community partners, because we can't provide all the services at a loss on a continuous basis, clearly. So we have to evaluate that.
Got it. And so, is primary care reimbursed at a much lower rate than, say, cancer care?
They are completely different reimbursement models for the services, but our primary care reimbursement is quite low. Unlike some others in our region, as John mentioned, critical access hospitals and some of our other partners in the community are reimbursed much better for primary care. With regards to oncology and some of our radiation services, it will vary quite a bit, but those services in general are still compensated at lower than cost. So again, our community support, such as our foundation, providing help with, we have a new linear accelerator, one of the pieces of equipment that really helps in cancer treatments, and the community stepping up to help us continue to fund those cancer treatments is really, really helpful.
Got it. Jim McIntyre has a question. Jim?
Interesting to be reminded, John and Jennifer, about the differential between Medicaid and Medicare. I was just thinking of a parallel effort with the legislature, or to the legislature, with respect to Medicaid reimbursement rates. Since that's a state program, federally assisted, particularly with the cost shift to the very small percentage, the 15 or so % of private payers, which includes government payers. It either comes out of the pockets of the individuals who are employed, or comes out of the pockets of the governments or businesses that provide healthcare to their employees, healthcare coverage to their employees. So another way perhaps to kind of improve the reimbursement or the revenue picture of the hospital is to impress on the legislature that they need to, particularly for hospitals in our situation, they need to have parity between Medicaid and Medicare reimbursements. It still won't get us to 100%, but we'll lose money at a slower rate with the Medicaid piece of it at parity. Just tell me if that's a realistic thing to think about doing while we're encouraging CMS to not hurt us again, if you would.
I'd say it's a very reasonable concept. I think, and OMC has really strived to take on that challenge. We've had a lot, dozens, if not hundreds of meetings with our state delegation on a regular basis. And they've listened to us, and we actually do have a very unusual add-on. We do get a little bit more money out of the Medicaid system than most other hospitals. And, as one of those very narrowly defined programs, it's for critical access only that are also public hospital districts. So we take the 75 hospitals in the state of Washington. The only two that qualify for that are us and Grace Harbor. And it's really been a lifeline. I think Grace Harbor would have absolutely probably closed by now if they didn't get that Medicaid add-on. So we get some, but there's only so much of an appetite in the state legislature for giving more money out to hospitals.
Yeah, it amounts, in my way of thinking, it amounts to sort of a hidden tax on businesses and individuals who are not Medicare eligible, or at the income level where they qualify for Medicaid.
Mm-hmm.
Yep.
Yes, Tim, I agree 100%. I think you and I talked about this just a little bit at the Sunrise Rotary meeting, and I was really impressed by your question. And I think you're right. As John had mentioned, we do have some assistance right now at the state level, and it's been great, but it isn't enough because of the dramatic percentage lower than cost that we're paid at.
Yep.
And to go back in history a little bit, we had a bill that was put into place back in 2014. As John was mentioning, there was a slightly higher rate for sole community hospitals that were also public hospital districts that were level 3 trauma centers. So there were very specific criteria. And the reimbursement was increased just a little bit for what ended up being OMC and Grace Harbor, because we were the two hospitals that met that criteria.
Yep.
Then in the meantime, we have gone back to our state delegation every biennium and asked for some additional funds, because we're still so far below cost. And as you said, it puts stresses on other parts of the system, including private payer, but also just including, the ability to serve the community and make change and progress forward. So we've gone back and asked for a budget proviso each biennium, and we've been able to achieve that thanks to Representative Theringer, Senator Vandeweghe, and Representative Chapman have all worked on that really hard for several sessions in a row. What would be really great to see is that budget proviso added to the state law. And it may be something that we're never able to do, but I do have it as a goal that one of these years in our legislative advocacy, that maybe the community could back us on that piece and get what's been an ongoing budget proviso that is really just sort of a piecemeal answer, get that written into the law that we were able to get passed in 2014. And that would be so much more stable for OMC and for our community, still below cost, but a better way of planning.
So Debbie had a couple questions about Jamestown and their reimbursement rates, and then also about Medicare supplemental policies. Can either of you answer those questions?
Well, I can take the Medicare supplemental. No, that doesn't mean that the hospital gets paid anymore. That only means that the patient has less out of pocket. That'll cover deductibles. So the patient doesn't pay as much, but that when Medicare sets the rate, that's what we get. And it doesn't matter if there's a supplemental involved or not, that there's no additional revenue for the hospital. And I'll let Jennifer chime in here as well. Yes, we've seen some doctors go to Jamestown. They have a little bit more favorable reimbursement, and they're able to, afford a little bit more, but we keep our salaries competitive because, the market's the market. You have to pay for the people. And if you're not paying market, you're not going to get them. There's also some culture differences of, formal hospital versus a hometown tribal clinic. I have a couple of really good friends that work there, and they love the environment there. So Jennifer, what would you add to that?
I think that's just a perfect answer, John. I would say that we have the utmost respect for Jamestown Family Health Clinic, and as I mentioned, some of our other community partners, known included, and we do have doctors move around. We have staff move around. We try not to view it at all as a competitive situation, but as one where we're serving the community. And my gratitude to Eric Lewis, who really, I think, was kind of a pioneer in that vision of having a community-based healthcare where we all work together. So from that perspective, we really adopted that. And if particularly in primary care, where we had some restructuring and so forth, and we're really trying to rebuild, if doctors moved around and found a better fit at another clinic, then I, for one, am fully in favor of that. It just means that we have to recruit more providers to the community, which is an ongoing effort, and we're trying to do that. And it all goes back to the economics, because as you mentioned, John, we have to try to meet the market, because everyone else in the state of Washington and across the US is recruiting those same providers. So to get them to Clallam County so that we have enough services for us all, we do have to have the reimbursement flowing to all of the healthcare organizations, including OMC.
I see Dr. Maxwell has his hand up, but Steve Bierman has asked a couple questions in the chat. Steve, do you want to ask your questions? There were some good ones. What can we do to help change the reimbursement rules? And then a follow-on, is it possible to attract research opportunities that may provide additional resources, talent, equipment, and funds?
The research question is an interesting one. I don't think you're ever going to pry that out of the custody of the major institutions like the University of Washington. They have their programs built around that, and I'd love to be able to do something like that, but we can't. We can barely recruit enough doctors to meet our basic needs, and to try and expand beyond that, when our number one challenge is housing. We may be able to find a really great doctor, but where are they going to live? And we're going to have that same kind of issue trying to stand up any kind of research program. So I wouldn't give up on that idea, but it's not a short-term solution.
And Lori put in the chat the link where you can submit your comments. So you can just click on the link to submit your comments. That's something that would be helpful. And she also put in there the email address to request a copy of a template letter, if you'd like. So, and Dr. Maxwell has a question.
Yeah, thanks. Mostly just a comment. I just want to follow up on the point that Jennifer and John made about the the collaborative nature. It really was led by the hospital. I neglected to mention in my presentation last week that we've had some recruitment success, but the hospitals play a big part in providing some recruitment incentives. It's actually helped us. So the hospital really has taken a collaborative approach with us in Jamestown, and all trying to just work to get providers to the community. I just wanted to publicly acknowledge that and thank the hospital for that. I also wanted to just give Jennifer and her team and John, the board as well, kudos. They gave a lot of credit to Congressman Kilmer, but really it was the OMC team that provided the education to him about what this actually meant, and kept that. That gave him the ammo to successfully advocate on their behalf. So I know it was a lot of work. I got to see some behind the scenes, and it was a big heavy lift. And thanks for your perseverance. And I'm glad to see it. The justice finally come through. It was a long game, but it's good to see it finally happen. So congratulations.
Thanks,
Thank you,
Dr. Maxwell.
Really well said.
So do you want to move on to the next subjects? We have 12 minutes left.
Oh, and I do want to thank you, Dr. Maxwell, for all of that. It's really, really good for our community that we work together, and we're so appreciative of you and our other partners. The next slide. I wanted to comment on the emergency group provider transition, which has been in the news, not recently, but a little earlier this summer, as we began our transition to a new group on July 1st. Our contract with our previous provider group was set to end on June 30th and expired on its terms and was not renewed. And at this point in time, we have a contract with Sound Physicians to begin as the emergency medicine provider group. And this says October 1st, but actually the first day of services they'll provide is October 4th, which just happened to fall better in the week. But that contractual transition is underway. And in the meantime, we have had locums providers and some of our former legacy providers who were with our previous ED group providing services in the ED. It's not been without difficulty. Change is hard, and it's been hard on all of us, especially some of the really, really unfortunate events that were the impetus to different aspects of the change. It's been really hard on staff and patients and just our community in general. That being said, we just haven't given up. We haven't had any moment where we've all stopped working. We've just made progress steadily, one foot in front of the other, some days harder than others. And we're seeing that the services continue in the ED. We're actually seeing minor improvements, and they're creating some optimism with our staff who are feeling quite a bit better about some of our statistics around patients who leave without seeing a provider or who are waiting long periods of time. Wait times in the ED are just historically something that we battle with, that probably every ED in the country battles with. And so it's a focus for us. And with the new group, we're really hopeful that the numbers, the trajectory that we're seeing currently with some improvement will continue. And I would comment also that this is a big change for us in terms of the ED provider group. So we'll continue to monitor it virtually on a daily basis. And our board has directed us to continue looking at this group that, as it comes in, and other groups, and make just very careful analytical decisions going forward, trying to just make the best decision for the best service for everyone in the county. And clearly, just to emphasize, it can't be underscored enough that our primary focus is on patient safety and trying to improve the patient experience. It's definitely not a perfect environment, but we are making progress, as I mentioned, every day, and just continuing those efforts. And we welcome feedback from the community, and just really trying to do our best on a go-forward basis. So I'll turn, if there are no questions on that, to a quick, and it does need to be quick, I see, comment on workforce. We continue to have, we have monthly variations and we have a challenging job market, but what you see by this graph is that we continue to have growth in our employee numbers. This number is 1,635. We've actually increased just a little bit since this slide was put together. That's our approximate number of employees. When I presented to the SQUIM Sunrise Rotary, this number was 290, estimated 290 openings at all levels throughout OMC. So I'm thrilled to announce, which might sound ironic, that we have only 251 openings right now, because that's actually a pretty significant drop. And we have needs in all the areas you might think of, including RNs, medical assistants, call center. We have many tech positions and administrative positions, just 251 of them, so too many to count. I'll make it quick. I had just pulled together some turnover rates because I thought it might be of interest to the community that OMC in general has experienced what the rest of the country, especially healthcare organizations, did during the COVID pandemic, where there was a higher than average turnover rate in 2021. We are back down to pre-pandemic levels in our OMC turnover rate, and our turnover rates tend to be quite a bit lower than the national average. So we're at 11.6% of turnover, where healthcare nationally is at about 24.9%.
Wow.
So we really do tend to hover quite a bit lower and have better retention, despite people talking about, moving, and we have some that leave the area and so forth, but our attrition rates are actually quite low. And I wanted to mention too, just because it's a spot of bright good news, that our hiring records have just hit the top of our charts in May through August, and culminating in the month that we just completed, August of 2022, our recruiters were able to hire and fill 100 positions, which is an all-time record for OMC. The top month ever previously had been 2 years ago, and it had been 68 positions filled in a single month. So the market seems to be turning. We have been working really hard on recruitment and advertising just everywhere we can think of, really working on workforce development programs. And I saw Mia Boster was on the call earlier, and I had a great discussion with Susie Ames earlier about how we might continue to work with our legislators on workforce development, because we need more trained labor, and we want to hire locally if we can. But the news is good right now. We're hiring and onboarding more employees than ever, and our records just continue to be set. I will comment, it's not a surprise probably to anyone who's been following healthcare, but our labor costs are up an incredible amount. So some of those numbers that John described earlier, Commissioner Nutter, regarding our economic challenges, are even further challenged by labor costs, which are up year over year 11%. So summer of last year to summer now, we have seen a $7.2 million increase in our labor cost. And the largest change is the traveling workforce, contract labor, so particularly with nurses as well as locums doctors, and that number specifically is up 426%. So it's a pretty large number, and the magnitude is hitting our bottom line. Labor costs are the highest they've ever been, and I provided just some quick snapshot numbers of travelers and how many we have, which are just compared to historical figures, they're at astounding numbers for us. So then I'll just conclude two quick slides. One is about monkeypox. It's been confirmed in Clallam County, and we have just the one case, but a handful of suspected cases. But it does look to be slowing overall statewide. This monkeypox virus is lowering, with the highest activity being recorded in King County. And we are set to be certified in our infection prevention certification again in October. OMC was the 4th hospital in the US to be certified in infection prevention. We are going on our 5th year, I believe, if I'm correct on that. And we were the first set of physician clinics that DNB certified in infection prevention ever in the US. And so we take it very seriously. We have an infection prevention department that is working on obviously COVID, obviously monkeypox, but continuing to just really try to keep everyone safe with the wide array of communicable diseases that we continue. And then lastly, I just wanted to end on another bright spot, which is a thank you to our foundation and to our community. The foundation, I talked to Bruce Skinner again this morning. He is just on cloud 9 with the record numbers that he's been able to raise for OMC. It's amazing that during the pandemic, somehow Bruce Skinner broke all previous records with fundraising. Our community just outpoured its support, and it was incredible to see. So for the second straight year this year, the OMC Foundation has already given over $1 million, and we're not through 2022. So Bruce says he doesn't know what the number will be for 2022, but it'll break a record. And just today at our board meeting at 12:30, Bruce is on the agenda to give $400,000 to present that to the board, and that's for a new CAT scan, as well as a $200,000 pledge, and that's all from a single donor. So the outpouring of generosity from our community has just been incredible. It's been amazing. And although it really doesn't shrink that delta, Colleen, that you spoke of earlier between cost and our reimbursement, that's one of the ways that our community has really stepped up, not only with legislative advocacy, but then also with foundation support. So just a huge thank you to everyone who's been involved in that. And we can't express our appreciation enough. And I made it with 2 minutes to go.
Thank you so much, Jennifer. Really appreciate your presentation. So with 2 minutes, does anyone have any last moment questions or comments? I see Council Member Rathbun from City of Sequim is on. And since CMS affected Sequim the most, and I think he was involved in recognizing the impact that would be, is there anything you want to share, Councilmember Rathbun?
I feel like I'm wading in the shallow end of the pool here. I did attend the lecture by your former director, and I went out and knocked on doors, and my perception was that there was a big response from the Sequim residents. And the other thing I'll add is I constantly get inquiries about when are we going to have a hospital here in Sequim? So the interest in healthcare here is very high.
Mm-hmm.
Absolutely. And thank you so much for that support that Sequim really engaged in, because you're right, there was so much that came from the Sequim community. And it would probably require another hour to delve into to all of the complexities around what the state will allow us to do with hospital establishing, independent and emergency room facilities and other types of clinic outreach programs. But we are, let's suffice it to say, continuing to work with the City of Sequim. We have a meeting with Matthew Heesh coming up just in a couple of weeks, the new city manager, and just really trying to delve into that problem and figure out how to provide more services for Sequim. It's a need, and we know it's there, and it's just a matter of navigating all the regulations and all the complexities that exist.
Thank you for doing that.
Great. All right. Well, thank you, everyone. And we will have this recording up on our website later on today. Choose Clallam first under the Coffee with Colleen tab there. And again, a reminder, Lori did put in the chat how you can get a template letter, and you can email her and she'll send it out to you. And also then the link where you can send that off to. So with that, I think we'll sign off. Thank you again so much, Jennifer, not just for today's presentation, but for all you do. Have a great day, everyone. Thank you.
Thank you, Colleen.